нього ж доповідь, ну нічого, ми тоді. О, Василь Іванович є. Проходьте до нас, будь ласка. Шановні колеги, ми розпочинаємо нашу секцію травми майже вчасно. Я думаю, що до нас...
Dear colleagues, we are starting this section now. Almost in time, I hope for more audience, and I am introducing the co-speakers, Professor Novitsky. No more introductions required. And you're the first to start. Later you will have your own glaucoma section, so the floor is yours. Thank you for invitation. Thank you for running these two important sections in parallel. Here is my report. And today we are going to discuss such a specific situation. Not during the intra-operation problem, however, in the late post-operation period associated with concussion resulting in traumatic dislocation of IOL. So, problems of traumatic IOL dislocation. The specific feature of this situation is the incorporated location of the IOL, namely when it is tightly located with the capsular sac. During the previous satellite reports, similar cases were reported. However, this encapsulation does not prevent the dislocation of the whole segment. The complex of lens, capsule and subcapsular cannot be sutured to iris. During subcapsular surgeries, it can be fixed to iris. However, under these conditions, we are facing the situation as is. So, what can be done? The case can be passed to vitreoretinal surgeons. Here, this case is managed by vitrectomy. The whole complex is located on the anterior hyaloid. The remains of ciliary fibrillas are removed, replaced to retina. The IOL is freed from the remains of vitreous body to make it mobile. Then the sac with capsular ring is elevated. Here is the accelerated video of the surgical operation. You see how fast they are fixed to the capsular bag. It is not that easy to pull it out. Later, the IOL can be cut into pieces and removed or fixed bag using polypropylene 10 to sclera. Even if the lens has got no haptic elements, the polypropylene loop can be attached. Here you can see the way it is attached. So the propylene is fixed, it is not absorbed. Then we're putting the IOL into central position and using ZAD plastics, enabling moving the thread deep into sclera to fix it tightly. And by pulling that thread, the lens can be positioned into central location. These operations have central drawbacks. There are big incisions. These threads can be associated with cutting of tissues and infections. I'm no longer making these operations. Previously, we were making the sclerocorneal sacs or bursa, the Hoffman's operation. The benefits of these methods is the formation of the bursa in the corneal area. Through this bursa, we are moving into the space. Using polypropylene threads, we are pushing them through conjunctiva and upper margins of the bag and moving it outside. The first suture goes through the capsular bag, the other one goes under the iris. Here you see the depiction. We are pulling two threads, pulling them out from the bursa, and by tying this thread, we are hiding all nodes under sclera. No conjunctiva is cut. The infection can get inside the eye. The thread will not cut the tissue outside. Sometimes no trace of operation can be seen at the second day. However, this is not an easy operation. Here are other possible complications. If the needle is pulled not through the conductor but right through the scleral tunnel, the tip of the needle can tear the margin of the iris away, because the incision through paracentesis decreases the mobility of needle, resulting in possible hyphema or hemophalm. Unless the needle is fixed in the conductor is removed and the eye remains inside the eye, so that it could potentially dip the whole complex of lens downwards. Now we are using the method developed by Kanabralov. This is not my surgical operation. The lens is being fixed. Practically the same goes. The conductor goes through the capsular bag. Polypropylene is inserted and pulled outside. Here the torical lens is fixed, therefore the meridional incisions were made. That gives the better fixation of the whole complex in the pre-established position. The same operations are conducted on the other side. The conductor is passed through the sclera, the capsular bag, while the other thread goes under the iris, forming a loop. A point of critical importance: the flanks should be made small. During the incision of sclera, an oblique incision should be made. Then the small flanks are hidden in the scleral tunnel, and the inflammation or tissue cutting or endophthalmitis would not develop. Here is another video with the variants of this operation. This case had a lens displacement. The thread was pulled through the Sione ring. During the fixation, I've been using the dull point thread. Instead of cutting, they pulled the whole complex upside. But when I released that thread, the thread dips in the depth of the eye, so this cannot be left like this, because in this way the complex remains unfixed, so it would get displaced at the next day. That's why we pull the Sione ring from the bag back. When we try to remove it fully, here I'm fighting the margin of the Sione ring and pulling it out, and you see such a short spud remaining after the improper fixation. The whole ring could have been pulled out. So during the extraction attempt, I can see the failure. So I'm trying the remains of the thread from the cyanory ring and making and repeating the whole operation. At the end, the result might seem beautiful, but in fact, that is not an easy invasion. However, the fixation can be made even without vitreoretinal surgeons, unless there is a displacement of the complex deep to the eye bottom. Thank you for your attention. Applause. My comment. Your report brings optimism. You have the same problems as I have. You're brave that you're demonstrating your mistakes and your doubts in these extra difficult cases. However, my question is, when the patient with lens dislocation arrive, however, the patients have absolutely blank history, and it turns out that the lens is a toric lens. What do you do in this case? Before picking a patient, we are making a refractometry. And during the distal placement, during the investigation, we can find out using the results of keratometry. So if there's a toric lines inside, we can put in the area of the maximum astigmatism. Of course, the posterior astigmatism is not taken into account, but that doesn't seem to be a critical problem. The refixation of the lens is a problem, is a much bigger problem. We can seal those incisions. However, we get a variant system also, with patients getting their imaging at Virion. That makes the strategy easier. Sometimes the lens remains on the eye bottom, and all you can do is picking it up. In such cases, I would think about backup and possibly could suture these openings and making some releasing corneal grooves. Next question. Are you releasing the lens from the capsule bag? I never do it. The vitreoretinal surgeon does it. That's a complicated procedure because as soon as you start doing this, a lot of problems emerge. Full vitrectomy is required. Moreover, the benefit of cataract surgery is that you fix the remains of the lens together with the bag, not resulting in any additional inflammation, and it is easier to fix. Only when the remains of lens remain on the eye bottom, this case brings more problems. So when the lens is inside the bag, you're just elevating it and fixing it together with the bag if the posterior capsule is intact. That is much faster. So if the circular structure remains intact but the lens is destroyed, then probably it should be done. Once we've made an opening with the forceps and hoped for a better end, but we failed, all resulting in inflammation and repeated operations associated with multiple problems. Thank you. We're thankful to you. And the next report is review of a clinical case of traumatic dislocation of eyeball into sinus, into nasal sinus, reported by Vinishkevich, and he's welcome. Dear colleagues, let me thank you for your invitation and let me present a clinical case of traumatic dislocation of the eyeball into nasal sinus. What is so special about this case? In foreign literature, 26 cases were reported associated with the displacement of the eyeball into nasal sinus. As far as you can see, various cases are characterized by enucleation in most cases, and the mechanisms of trauma were different. Mostly were associated with accidents. Respectively, as a result, the reconstruction of orbit has been performed in order to perform an organ-preserving operation. In our case, the female patient that arrived, she was 68 and she had a trauma. She thought she was hit by a branch of a tree, and the blow itself was powerful enough to displace the eyeball and damage the lower wall of the orbit. And the eyeball inside was displaced, but that was unnoticed due to severe edema of the surrounding tissues, orbit, nose, and other areas. During examination, no trace of the eyeball was noticed in the orbit. The vision acuity was lost for this eye. In the parallel eye, the vision acuity was 60%. The condition was associated with a severe hematoma in the facial area around the orbit. It was highly intensive. So the eyelids could not have been widened. So the eyeball could not be seen. In brief, the eyeball of the left eye was had purely age-related damages, without any additional comment. When the patient arrived, we have conducted the simultaneous facial and cranial operation, and after we have run a computer tomography and found the eyeball displaced to his nasal sinus without any rupture and loss, we have taken a decision to perform a recovery of the eyeball's position. We have conducted a hymerotomy, elevated and fixed the eyeball with an access through the anterior wall of the sinus. We removed the remains of bone shards. The eyeball was removed back to the orbit using what's the special feature. We used the Foley's catheter and pumped it up. And this way, using very tender manipulations, we have elevated the eyeball from the nasal sinus into the orbit through an additional opening under the lower nasal concha. Here you see the incision in the maxillar area. Continuous sutures were used in the end. Here you see the whole operation. So the situation at the next day, the eyeball, you see two photos, prior to operation and after the operation. The eyeball has medium level of irritation. What's so special about the eyeball? Neither the optic nerve nor the external muscles were torn or broken. So, using the Foley's catheter, we managed to elevate it up and place it in the orbit, thus recovering its position, making the reposition. The patient, in fact, had no special follow-up, but we have noticed that the eyesight of the patient has recovered. The mobility of the eyeball was decreased but still present because no muscle ruptures were reported in sclera. Of course, the cornea damages were reported with a certain hampering of the pupillar reaction. The lens was a little bit blurred, however, these changes can be considered age-related. The eye fundus was clear with a definite picture of the optic nerve, so the whole changes were associated with age only. The patient was receiving supporting therapy. In 10 days, the conjunctival sutures were removed. The patient received some recommendations to continue the outpatient treatment. Foley's catheter has been removed in 21 days. Then we have reconstructed the orbital wall using the individualized implant. After this, the patient has never returned because she was choosing a hospital for further recovery of the orbital wall. Here are the images, later images. The ultrasonic imaging of the eyeball demonstrate age-related changes as well as particular changes of retina. However, the optical nerve is practical and damaged. You cannot see any rough changes here, though the peripheral field of view has its concentrated narrowing. So this cannot be seen through the ultrasonic imaging. The eyesight fields demonstrate changes associated with the presence of the pre-operational post-traumatic damages. The patient has never addressed to us ever later, so we cannot trace down the later period. However, she fully realizes the need for the reconstruction of the lower orbital wall. Thank you. You have reported everything in detail. Sharing my experience with you. Long ago, we had a patient that had eyeball displacement into nasal sinus, and the vision acuity at the pre-operation period through the nasal pathways was still remaining. After the operation and reposition, her eyesight improved, supported by operation, anti-inflammation therapy, etc. Something more. One of my first books was Sketches in Ophthalmology of Everback. With a similar case, there was a patient there that had some sight through her nasal pathways after trauma because of the displacement of the eye. Professor Nowitzki is going to perform the next report. Dear colleagues, it's a pity we're getting more and more experience on removing the internal foreign bodies from the eye, including the posterior capsular axis removal techniques. Our results demonstrate that more than in 1/3 of cases, removal of foreign bodies with minimum damage of surrounding tissue is required. So, Inside there's a fibrous membrane, and here the internal body, foreign body, should be removed. If you just using the sclera for removal, you have to pass through the vascular wall. If passing it through the cornea, you'll have to walk through the lens, so both ways have obstacles. Probably this is associated with a higher remaining damage of the eye structures and possibly a hemorrhage. This is how the situation looks. The lens has been implanted previously and we didn't want to move anything there, so we're removing that foreign body. Through the scleral opening we have widened. So, what exactly are the medics, the doctors, releasing? So the transplant lens we're now going to pick up. Next, the foreign body can not be that large. This technique requires precision surgery of cataract and conduction of posterior capsular axis. Therefore, this is important. In this case, the rupture of the posterior capsule has been reported. Therefore, continuous capsular axis is required. After this, how exactly the lens can be returned to the sac, to the bag? Technical issues. In order to protect endothelium of cornea during posterior capsular axis, viscoelastic tissues should be removed continuously. As for the foreign body, it is removed to the anterior chamber and cut by another forceps. It is being fixed along its main axis. So, under these conditions, the foreign body that sinks inside the vitreous body the cornea is protected by arthrodecalin. To remove the foreign body remains far from the retina as far as possible. Here we're catching the capsule with another pincer. And removing it. Here is the partial posterior capsular axis. Because the traumatic rupture of the posterior capsule is not associated with any ideal operations. However, even partial capsular axis can result in better outcomes so that the whole complex of the lens can be fixed. So, this is how the foreign body is removed through the posterior capsule. Traumatic cataract is reported here. Here we are coming to the posterior part. Vitrectomy follows. The foreign body is captured. It goes to the anterior chamber. Luckily it gets into the angle of the posterior camera, but not through the posterior capsular axis. And then we are removing it through paracentesis. However, the foreign body can fall to the eye bottom through the posterior capsular axis. What can be done here? Before the foreign body is removed, artificial lens can be placed that blocks the capsular axis area. Here, the foreign body is lifted, moved through the rupture of the posterior capsule and into the anterior chamber. The foreign body is fixed with a forceps and the iris is replaced. We're removing the corneal sutures and taking away the foreign body through the existing opening. There was no other way for this operation. So, what's the conclusion? Removal of the foreign body through posterior capsular axis is a good option. The limitations are transparent crystals, not subject to removal, and the size of the foreign body. The conditions of removal is the good functional status of the cataract and skills of capsular axis. I'm inviting you to the 5th International Symposium that will happen in July in Lvov City. Thank you for your attention. Probably there are some questions. Thank you for your hard work and support of the militaries. So the next report, metal versus eye, the hidden threat. Reporter Dr. Bondar. Dear colleagues, I would like to share the problem of siderosis, and the topic is metal versus eye, hidden threat. Among the penetrating wounds, penetrating wounds are one of the most common damages of the eye, associated with a significant risk of vision acuity loss. Different authors reported in a very high number of such patients. If the foreign body is detected in time, siderosis can develop within 3 weeks to several years and result in loss of eyesight. The mechanism of siderosis development is the iron molecules get oxidated, turning into an O5. So the availability of free ions of oxygen make it a good structure, resulting in possible toxic effects and in cellular death. Diagnosing. First, history should be collected, with a clinical examination followed. Presbyomicroscopy should be used on a narrowed pupil. Check for presence of scars. Check for iris glaucoma. Also pay attention to blurring of the lens, both generalized and focused. And please check the bottom of the eye. Foreign bodies should be suspected under these conditions in the anterior chamber. Experimental methods include different types of X-ray, CT, the biometrics and scanning of the anterior and posterior areas are electrophysiological methods of investigation. Siderosis symptoms include vision acuity loss, iris heterochromia, which is reported by patients themselves, getting start to their ophthalmological examination, blurring of the lens, and other features. In our report, I would like to present two patients. They had a history of explosion. During the initial examination and X-ray of the orbit, no foreign bodies were found. However, within several years after the trauma, the patients were reporting vision acuity loss and iris color loss in the damaged eye. So, in the first case, we know that the patient had his initial surgery processing, and within 1 month, the phacoemulsification has been performed. The patient addressed within 2 years after trauma with vision acuity 60 and correction. The intraocular pressure was right. So, in the X-ray of orbits, the foreign body has been found. With a low intensity, the size was rather small, 6 to 4 to 2 millimeters. During this CT, the position was similar inside the eye and outside the eye. The patient has oligos artifacia. Flastron in order to remove the remains of that part, because it is the key to my nephew's future development. Then, using sclerocompression, we're performing the examination of the eye fundus. And here you found the foreign body with one edge fixed to the extremity. The widened sclerectomy will be required for this operation. However, pressing it once more, in this case, is complicated by one point sticking. So, prior to examination, it should be removed, not to harm the retina, resulting in its possible displacement. As far as you can see, the trauma has happened 2 years ago, so everything is absorbed. Now we're using the magnets. One more important thing is not to leave the remains of the metal agment. Will always leave some traces. In this movie it was missing, however we are performing a laser coagulation at the place where the foreign body is fixed, and choroid with a gas tamponade remained here. Within 1 month after vitrectomy, the eye was quiet, the vision acuity was up to 155. The next patient is a warrior with an post-military explosion. In this case, we have detected a foreign body, rather big one, associated with a retinal detachment. We have met that person. So here, the thorough surgical treatment has been performed with phacoemulsification and making an incision in the posterior capsule, where we're using catheters to make this. So we are also using multi-organic substances in order to perform the protection. So in order to remove it from the fibrin tissue, we're elevating it slowly and inserting viscoelastics to protect the corneal epithelium. The test of cornea should be performed in order to check its status. You should figure out the status of the plant, increasing it up to a required volume. After this, we can report the fluids into it. Then the sutures over paracentesis were made because these are the degenerative conditions of the eyeball associated with a small rupture. We are changing the air to silicone, trying the laser coagulation, and during the second stage, the infraretinal operation is required. So the patient will be receiving follow-up, however the treatment protocol will remain. So based on the existing methods, the ethic membrane is still approaching. So all iron-containing elements, despite of their location, are subject to removal as soon as possible in order to avoid hemosiderosis and other complications. In this picture, it is important to pay attention to the collection of data, make a sort of ophthalmology advice, and run a similar decision with an orbital computer tomography and the full pair. Thank you. Probably more questions or comments. Then the next speaker is introduced. She's the head of the Reconstruction and Recovery Microsurgery. Her report is about the role of vitrectomy in treatment of endophthalmitis of different etiologists. When we were planning this section, we planned to couple the logically connected reports. Previously, our colleagues described as the removal of foreign bodies. Another one reported what happens when the metal-containing foreign bodies remain. But endophthalmitis is one of the other possible complications. Dear colleagues, now we are going with the report. Endophthalmitis is an acute inflammation of internal eye membranes associated with exudation into the corpus vitreosus. Endophthalmitis can end up both with loss of eye and with a progression of vision acuity. There are different kinds of endophthalmitis. Exogenous one and another one associated with corneal ulcers or in patients that are wearing contact lenses, especially the control lens. So the endogenous endophthalmitis starts with intraocular infection due to hematogenous spreading of the germs from a far away location of infection.
От деякі на слайді ви бачите в процентному відношенні, які бувають ендофтальміти, і ви бачите, що після травматичної ендофтальмії, напевно,
As far as you can see, the post-traumatic endophthalmitis reports this level for 17%, with the lower doses, lower levels for the first parts of apparatus.
Вторинна імплантація теж дає екзогенний ендофтальміт.
The same things can be happen after the displacement of cornea, that is done to recover the eyesight. However, sometimes the results are unpredictable. The same concerns other operations.
Які буває ендофтальміт?
So,
Будь-який ендофтальміт.
what
Це
are
бактеріальний,
the
стафілококи, стрептококи, синегіни.
factors of endophthalmitis? First, bacterial ones. As far as are reported today, sometimes we're making a microbiological assessment, not supported by any pathogenous flora. You all have an experience of removing the dead bodies from dead endophthalmitis. With those terrible results of epidemiologic studies, once again, once we had enough endophthalmitis caused by fungi. However, endogenous endophthalmitis is most common. You all know the clinical system: pains in the eye, rapid decrease of vision acuity. Other symptoms are edema of lungs and chemosis of conjunctiva or infiltration of cornea, slowed pupillar reaction, photoreaction, the yellowish tint of skin. In case of endophthalmitis, the reflex is rather dim. However, in case of working endophthalmitis, it makes the nice places even more nice. For endogenous ophthalmitis, chorioretinitis can be found with a further. For a long time, treatment of all types of endophthalmitis was based on the results of 1995. This report has been randomized. It has been dedicated to the role of vitrectomy possible. The study was focused on microbiological evaluation of bodies, retrieving the list of flora found. We didn't expect the intra-atmospherical infection. The early vitrectomy was performed on a vision acuity a little better than usual. So, if the vision is preferred but a little bit worse than nothing, such vitrectomy cannot be recommended. So, transparent endophthalmitis were not required, and patients with fungal funded mycology is not required also.
Але, на жаль, це дослідження з 1995 року існувало дуже довго і ще багато робіт наукових.
It has existed for many times, this method, and many reports indicate this is the master of cornerstone for us. Are there any cases?
Проводили за останні роки, вони мають дуже суперечливі результати.
Some surgeons indicate that such representation of vitrectomy gives you a very bad prognosis, while another thinks that it should be required under all conditions. However, in these cases, early vitrectomy is required, they say. And another group is individual approach, individual direction, and indicated vitrectomy. Moreover, except for guidelines on endophthalmitis, there are opinions of surgeons who report their cases in literature. So, in recent years, most vitreoretinal surgeries treating endophthalmitis are rather to perform early vitrectomy, and as of now, early vitrectomy is the most reliable method of choice for treatment of endophthalmitis. Early vitrectomy enables blocking of the infection which is a basis for the endophthalmitis, and the vitreous body. Vitreous, it prevents other conditions and prevents vitreoretinal tractions, possibly resulting in displacement of retina. In case of endophthalmitis, vitrectomy up to the medium level can be used without provoking the displacement of the posterior membrane. In case of mandatory removal of the posterior hyaloid membrane, this is performed very aggressively, and unless the posterior hyaloid membrane is removed, the operation cannot be complete. No active provoking of the displacement of the posterior hyaloid membrane is required because the retina might be infiltrated or necrotic. Therefore, hyperactivation of the displacement of the posterior membrane can result in ruptures. Therefore, in order to stop the infectious process, central core vitrectomy without any detailed interventions can be made. Modern vitreoretinal surgery is more safe. Therefore, the more often it is used for treatment of endophthalmitis. Previously, years 50,
20
Mevio
кінечники, тому
were
більше
using.
немає всяких ускладнень. На сьогоднішній день реально
Most
міні-інвазивна
of complications
вітреогенальна
were
хірургія
associated
є більш безпечною при
with a
виконанні цих
microinvasive
маніпуляцій.
surgery, which
Ну і,
considered to
звичайно,
be the
початкове лікування
most
ендофтальміту
safety.
є емпіричним і починається з
The
використання системних та
treatment of
нестевих антибіотиків
endophthalmitis is
широкоспектру дії.
initiated with
Це фторхінолони,
antibiotics, both local and
циклоспорин та
systemic,
антигрибкові препарати.
fluoroquinolones, and
Після системних та нестевих
cephalosporins. After
антибіотиків
local
виявлено
antibiotics are
можливості
used,
проведення
if
вітріоктомії,
vitrectomy
інтравітреальної
cannot be
проведення
done,
ін'єкція
intravitreal
антибіотиків.
injections
Сучасні
of
рекомендації
antibiotics
щодо
can be made.
інтравітреального введення антибіотиків такі. При
The
паркуванні
indications are as follows:
1 мг
vancomycin for bacterial
із
microflora,
разом в одному шприці з цефтазидімом.
together with
Тобто грам
ceftazidime,
негативну та грам
influencing both gram-positive and negative germs. The doses of ceftazidime is 0.25 milligrams per 1 milliliter, so both drugs can be injected in one syringe, providing a wide spectrum of activity. Moxifloxacin effective use has been reported. Sometimes Quinax can be used. However, we are not sure that this procedure is really required. While vancomycin and ceftazidime, about amikacin, it is more toxic. Therefore, it is practically not used in recent years. In case of fungal infections, amphotericin B or voriconazole is used. Amphotericin B is practically missing in the apotheks, and voriconazole is also a toxic medication, which is widely used as a systemic drug, not as an intravitreal drug. It is known that the bacterial degradation products and the antibiotics itself have a toxic influence on retina and optic nerve. The symptoms are hemorrhages, neuroretinitis, and the atrophy of optic nerve. These are the examples of treatment. As far as you see, it is endophthalmitis there, with a large fibrin film in the anterior chamber. Look here at this spot. Here is a suture for fixation of the lens. When the suture breaks through the conjunctive, the risk of endophthalmitis is even more because it's the entry gate. Here are the results for the vitreous body with the blurring of the vitreous body. Some of them are seen intraretinally, some of them are on the surface of the retina. They are tightly fixed to the retina, while the intraretinal ones would be absorbed during treatment, those blurred areas. The next clinical case, you see the transparent lens, the transparent media with an active endophthalmitis under the intravitreal administration of anti-VEGFs. As far as you see, the exogenous endophthalmitis starts on the anterior side, so the vitreoretinal surgery results in minor or non-existing changes. Therefore, timely vitrectomy practically results in no toxic effect on the retina and has good results. The next clinical case is intravitreal internal foreign body. The anterior part is good with a transparent media. However, it is associated with severe endophthalmitis, and at the place of the foreign body location, the local endophthalmitis is rather severe. Here, the anterior hyaloid membrane is removed and the rupture of retina is diagnosed with the densening and blurring of the vitreous body. Probably it's the entry point of the foreign body. The foreign body has been removed diasclerally in our clinics, followed by laser coagulation of retina and silicone tamponade because the rupture there is rather large. The next clinical case is also endophthalmitis, starting with the small clots of fibrin in the anterior chamber. This fibrin clot is removed, followed by foundation of endophthalmitis on the retina in the posterior part. So timely vitrectomy enables demonstration of foreign bodies and seeing the ship body. So, timely vitrectomy is a key to an effective and safe profile. Next point, you see the penetrating wound. Iris retractors are used, followed by intensive endophthalmitis, which can be found on the periphery and the posterior part of retina associated with necrosis, a massive necrosis, resulting in advanced endophthalmitis. So, early vitrectomy is much more useful than letting the process to become advanced. So, timely diagnosing and treatment of endophthalmitis result in preservation of vision acuity and eye functions. Vitrectomy is the key treatment for endophthalmitis. It enables mechanical removal of bacteria and toxins from the eye and avoiding eviscerations. Previously, vitrectomy has been recommended in endophthalmitis of bacterial and gram-negative etiology. If early vitrectomy cannot be used, antibiotics are recommended. because they are blocking the infection, however, have the toxic impact on retina. Thank you for your attention.
Дякую, Оксана Степанівна. Ну і враховуючи регламент, я
And
думаю, ми прохання
considering the time
притримуватися
course,
сесії. Наступна
we'll avoid
доповідь
questions. The
буде
next report will
представлена
be presented
уповноваженим
by
офісу
the
співробітником відділу посттравматичної патології ока,
Department of
глаукоми та патології
Post-Traumatic
кришталика Татаріновою Юлією
Glaucoma
Олександрівною
and
на
Lens
тему хірургічна
Pathology.
тактика при
It
вторинній
is about
посттравматичній глаукомі
surgical
в сім'ї з
strategy
наслідками
in
вибухової травми.
post-traumatic glaucoma in patients with the explosion trauma. Dear colleagues,
Вторинна посттравматична
secondary
глаукома
post-traumatic glaucoma is associated with various pathogenesis,
а іменно саме підвищення
namely
внутрішнього тиску
elevated intraocular pressure can be associated with the changes in the anterior chamber, destruction of the drainage apparatus, changes of ciliary body, inflammation as a result of multiple operations, and a combination of these factors as well. The decrease of intraocular pressure in a post-explosion eyes during glaucoma operations faces certain problems like aniridia, iris blurring, iris transplants, changes of sclera at the locations of glaucoma operations. So it is impossible to create a standardized approach to such eyes, and the estimate intraocular pressure in such eye is a problem. We have examined the combined tactics of transclear contact compressive coagulation of ciliary body within, followed by glaucoma operations. We had 2 patients with secondary post-traumatic glaucoma resulting from an explosion trauma. Patient had a history of initial surgical processing, phacoemulsification, a post-traumatic cataract without implantation of the lens, and transciliary vitrectomy. Both eyes had scars of cornea, edema, scleral staphylomas, and general inflammation associated with a critically elevated intraocular pressure, vision acuity normal, and plus 10 on another eye. The intraocular pressure was elevated. The tonometry demonstrated over 40 millimeters. Patients were receiving antihypertensive drops and carboanhydrase inhibitors twice per day. Patients had 3 series of laser coagulation of ciliary body with a diode laser, Quantal Medical, using the anesthesia was drop-like with an additional retrobulbar one. The transcleral contact coagulation was targeting decrease of intraocular pressure, which was initially maximum and critical. We also were targeting safe glaucoma operation at the second stage without any intra or post-operation complications, with decrease of corneal defections, decrease of neovascularization of iris, and lower post-operation hemorrhages, which all were provoked by elevated intraocular symptoms. So we wanted to make an anti-glaucoma operation possible. Pre-operation preparation, installation of antiseptics, considering possible contact method of laser introduction, anti-inflammatory drugs, NSAIDs, and parabulbar injections, considering the presence of scars and hypertensive edema. Preservative-free drops were used based on hyaluronic acid with the properties of bioprotection and regeneration. We also were using the glycerol solution and oral inhibitors of carboanhydrase at the day prior to operation. The prevention of scleral perforation was based on using the slit lamp, which enable detection of the most dangerous areas of sclera that should be evaded during the operation. The parameters of laser were up to 2 volts. The number of flashes was 25. Additional flashes were used in other zones, except for dangerous places in the areas of previous surgical interventions. Wavelength 710. The normalization of internal ocular pressure was slow. At the first day, the average decrease of intraocular pressure was 15 millimeters without any stable hypotensive effect. However, the decrease of pressure after several sessions is possible within several days, as well as elevation is possible after particular sessions. Long-term effect is possible when the pressure is decreased within 2 or 3 months, or even 2 weeks, or within a month, or even hypertension resulting in displacement of vascular membrane was reported. The progression of vision acuity loss recovered, lesser inflammation reactions were reported, and visualizations of anterior chamber structures improved, and the neovascularization parameters improved also. Within 1 month after the laser introduction, the average decrease of intraocular pressure was insignificant to maintain its function. So during stage 2 on one eye, the implantation of Ahmed's valve was performed within 1 month, and on the other eye, the sinus trabecular iridoectomy was performed. Here you see the valve implantation with the coverage of the scleral transplant. These patients were examined for some time after the operation. The pressure in patients with the Ahmed's valve at the first day after the implantation was 20 millimeters, and within 4 weeks it was 22.4, and in patients with penetrating glaucoma operation it was 14 at the second day, and within 3 days it was still 18 millimeters. Conclusions: in patients with secondary post-traumatic glaucoma, the transscleral coagulation of the ciliary body before anti-glaucoma operation enables decrease of intraocular pressure to minimize the complications level. It enables the decreased amount of oral preparations administration and results in better visualization of the anterior chamber structure for better surgical operation. Thank you for your attention. Thank you. Now, the next report will be online. It will be presented by Ms. Kapshuk, Center of Microsurgery. She's specializing on bilateral combat trauma. Here she is. Can you hear us? We can see you well, but we cannot hear you yet. Good afternoon.
Зараз декілька технічних затримка, але дальше. І доброго дня, шановні колеги.
Good
Вибачте
afternoon,
за
dear
затримку.
colleagues. Sorry for a delay.
Вашій увазі хотіла би сьогодні
I would like
підняти
to
проблематику
present the problem
досить поширеної
of a
ситуації, яку ми
rather
сьогодні спостерігаємо.
common
Це безпосередньо бойова
situation,
травма
a bilateral
наших
combat
захисників.
trauma.
Наш підрозділ Центр
Our
мікрохірургії
team of
ока з блоком очної
microsurgery
травми є
with an
підрозділом
ocular trauma
профільної
block
вузької
is a
лікарні.
part of
Основним принципом
clinical
відповіді
hospital,
мультидисциплінарний
which is
підхід,
focused on
тобто фахівка, коли ми маємо
multidisciplinary
справу з
approach
політравмою.
for
Коли
polytrauma,
задіяні всі хірургічні
when
підрозділи
all
нашої
surgical
лікарні.
teams of the hospital are working.
Хворі, які поступають до нас,
Our
військовослужбовці,
patients,
свободні
usually the military
евакуатори, вони
people,
можуть зразу потрапляти в
can
такі
get
підрозділи, як
directly
реанімація,
to
чи судинна хірургія,
resuscitation
чи
or
травматологія,
vascular
де в першу
surgery or
чергу
trauma surgery,
враховується,
where
визначається
major
питання
damages
стосовно
are
стабілізації
considered
вітальних
and
функцій.
their vital
І,
functions are stabilized.
звісно, ці пацієнти
These
можуть
patients,
пересуватися між різними
in the
підрозділами
meantime,
нашої
can
лікарні.
be rotated between various teams,
Потрапляючи в наше відділення.
sometimes
Всі
getting into
пересування
our department.
військовослужбовців
All
відбуваються
movements
під
of
чітким і ретельним
our
контролем
patients are controlled by the ophthalmologist because they have a staff consultant for each department. According to the evacuation template, the patients with the processed incoming wounds are coming to us. They are coming from the war zone hospitals. However, we are dealing with the deeper traumas, namely hemophalm fibrosis, traumatic cataracts, retinal detachments, displacements, endophthalmitis, and foreign bodies. Speaking about the changes of war, according to the statistics, and they say that during the 20th century, the damage of eyes during the First World War, Second World War, and Vietnamese War demonstrates that open traumas of the eye was observed in 30% of patients. 50% had foreign bodies. As of now, the situation is different. The combat changed. The combat factors changed. And in 71% there is an open ones of the eyes, with 70% having foreign bodies and perforations. As for bilateral wounds, previously it was very uncommon before the war to see the patient with a bilateral trauma. And during 3 years, since year 19 to year 22, this percentage was only 0.5. As of now, during the 3 years of war, we have experienced over 20% of bilateral ocular trauma, and the percentage of patients with eye trauma has increased at least twofold, as far as you can see by the statistics since year 22, when initially we had only 9 patients with bilateral damage. Now we have 19 patients with such traumas. There is a tendency for the change of the foreign body profile. Initially, we were evacuating big shards at the beginning of the war. These are our photos. These were bigger shards of metals, sometimes where they were up to 1.3 centimeters in length. So these were large shards, and they were magnetic. As of now, there is a tendency for smaller size of the foreign bodies. These are small darts and small shards made of alloy, and they are not magnetic. and the number of that foreign bodies is significant. Sometimes we have removed about 7 foreign bodies from the same eye. The number of the damaged eyes is fully associated with the intensity of combat in a particular area. The obstacles are loss of vision acuity or complete loss of vision acuity, and the psychological factor is also meaningful here. The first issue they have when they come, they're asking, which eye are you going to operate? Actually, this is also an important question for us. Which eye shall we start with? With a more easy damage or heavier damage? The presence of the inflammation process defines the stages of the medical assistance and the volume of the operative intervention. As an example, here are several cases. A young girl who arrived with a bilateral damage of both eyes. Her diagnosis was explosion trauma, condition hyphema, hemophthalm, iridodialysis, internal foreign body of the eye. First, we considered that it was inside the sclera and foreign body in cornea, in deep layers of cornea. The girl was immobile. Her both legs were immobilized and she had a lot of other problems. So we started operating her in a step-by-step way. For example, we've removed the foreign body from the left eye in the traumatology department using this slit lamp with the following stages in our department. From the very beginning, we decided to conduct a combined surgery of both chambers. During the removal of cataract, we have discovered that the corneal sutures are imperfect, so we replaced the corneal sutures. Then we moved to the posterior chamber of the wall. We conducted a vitrectomy with the removal of the vitreous bodies with vitritis, where the foreign body was located. During the examination and the revision of the cavity, we found there was no foreign body at all. And during the vitrectomy, we had a diaphanoscopy and trying to visualize it when we find it that it's under the mucosa. We did the transconjunctival removal of the foreign body. Here it is. Actually, in the right eye, it flew through the cornea, across the temporal side. It penetrated the lens, the retina, the eye wall, and here it comes. It was in the equatorial zone, such a big shard. The next stage was implantation of the lens. We were using the 3-component lens, which was put on the remains of capsular rhexis, followed by an iridoplastics with 2 sutures on iris, forming a pupilla in this way. Within 1 month, our patient demonstrated 0.6 vision acuity, and within 5 months, the photo is on the right, his vision acuity was 8 bands. As far as you can see, on the cornea, on the opening side, the stable cataract is forming. Another case, the patient arrived with a bilateral damage of eyes. He had a scalped wound with insufficient sutures, intraocular foreign bodies in the right eye, traumatic cataract, No visualization was performed in the posterior part, except for X-ray on the left, where he had a penetrating wounds. We have found visus zero and panophthalmitis. We have taken a decision for evisceration, and on the next day we have performed an evisceration. Within 2 days we performed a secondary maintenance of the scalped wound and conducted a vitrectomy and phacoemulsification with a removal of foreign bodies from the eye wall. The visualization was poor because cornea was damaged and edema was significant. Therefore, we have conducted deepithelialization, which is often used in the posterior part of the wall. After the focal laser coagulation, we finished it up with a laser coagulation. When the air have absorbed, the patient demonstrated vision acuity of 2 bands. Within 2 months, we have conducted a continuous operation forming a pupil for better fixation of the intraocular lens. Within 1 year, he demonstrated 8 bands vision acuity, and within 1.5 years, he demonstrated the vision aggravation of 6 bands. Speaking about the keratoplastics, it is still considered. You can see the changes of the cornea with a cataract in the area of the scalped wound. Another case, a recent one. Tomorrow we are planning to conduct an operation, a bilateral trauma of both eyes, a penetrating corneal wound of the right eye with a traumatic cataract and the presence of foreign body, the scleral penetrating of the left eye with a foreign body on the level of vitreous body basis and high vision acuity. The intraocular pressure is stable. You see his computer tomography demonstrating foreign bodies on the right and on the left. We have found a foreign body inside the left eye on the basis of the vitreous body. I'm using an opportunity to listen to your opinion, dear colleagues, about a patient. What could be the strategy? What would be the first eye for operation? So, conclusion, the number of patients with bilateral trauma of eye increases. They require monitoring by ophthalmologists. The prognosis of vision acuity and rehabilitation is not always positive. Everything depends on multiple factors. Of course, we wish for better algorithms. However, I do understand that this is impossible because there are many questionable issues for consideration. The big number of wounds is found in young males that require social adaptation and deserve for a happier life. I'm thankful to my team for support, for being close to me. Here you see us with our patients who are becoming our friends later. Thank you for your attention. Thank you for your report and good results. Our section is delayed and we have to continue, therefore we will discuss your question later. The next report, reconstruction surgery of combat trauma, tradition and innovation of Filatov's school. The head of post-traumatic trauma, glaucoma, and lens pathology.
Дякую, шановні колеги.
Dear colleagues,
Сьогодні така наша
today
доповідь, вона більш
our
є
report is a
підсумовуючою
summarizing one
певний період часу
for a certain period of
це
time.
і період часу на сьогоднішній конференції, і це
This
остання заключна доповідь
summarizing
нашої секції.
of our
І вона
section,
буде присвячена
and it will be
обговоренню
dedicated to discussion
дійсно традицій
of
і
tradition
інновацій.
and
Бо
innovation
тільки на підставі того досвіду багаторічного,
based on
який
the
ми маємо, який ми
vast
отримуємо від
experience
своїх
we are
вчителів,
getting
ми
from our
можемо
teachers.
працювати і ми можемо
We can continue
створювати
working.
якісь нові досягнення, нові технології. Я хочу сказати, що наша конференція цьогоріч
Our
проводиться
conference
з нагоди
is
150-річчя академіка
dedicated
Володимира Петровича
to the
Філатова.
anniversary
Але
of
не можу не
academician
сказати, що
Filatov.
цьогоріч виповнюється 60 років з дня
Today
основання нашого
it is 60
відділу
years
посттравматичної
of
патології.
post-traumatic damage
І першим
exists,
завідувачем
and the
була
first head of
після
department
створення
was
цього відділу професор
Professor
Скрипниченко
Skripnichenko.
Зинаїда Михайлівна. Можу сказати, що це доволі символічно для нас
It's rather
зараз,
symbolic
оскільки професор Скрипниченко
because Professor
починала свою
Skripnichenko
практичну діяльність як бойовий лікар.
was a
І так
combat
співпало,
medic,
що початок її практичної діяльності
and her
він припав
practice
на часи
has
Другої
begun
світової війни,
at
тому
the times of
перша
war.
завідувачка нашого
So the
відділу,
first
вона
head of the
також мала
department
справу з великою кількістю
had
постраждалих внаслідок
many
бойових дій.
had a vast
Ті уроки,
experience of
які
combat
були
trauma,
створені попередньо в нашому
and her
відділі,
combat
вони з роками,
experience with time
множились,
were accumulating and
вдосконалювались і
multiplying
впроваджувались.
and
Саме
widely
професор
implemented.
Скрипниченко піднімала
Professor
свого часу питання
Skripnichenko
відносно організації системи
has
надання
organized the
офтальмологічної
system of
допомоги при травмах ока.
ophthalmology
Ще тоді
aid in
адміністрація
case of eye
інституту
trauma,
і надалі
and the
наступні
administration of the
завідувачі
institute
нашого
and the following heads of
приклали
our
дуже багато
department
зусиль для
paid a
створення
lot of
наказів
attempt
про створення
to develop
офтальмо-травматологічних
the
центрів
guidelines
при обласних
for
стаціонарах.
ophthalmology
В
centers.
різні часи
in the region.
керували такі видатні
The other
вчені офтальмохірурги, як
scientists
професор Логай,
like Professor Logai
Венгер,
Wenger
доктор медичних
and
наук,
Dr.
старший науковий
Krasnovid
співробітник Красновід Тетяна Андріївна.
were the heads of the
Те, що
department.
ми маємо на сьогодні, це
And
величезний
actually,
пласт
as of
знань,
now,
вмінь,
we have
технологій.
accumulated
Хочу
great
зазначити,
experience
що
and
станом на
skill and
зараз в нашому
technology.
відділі
As
виконується
of now,
повний спектр
we are
хірургічних
running a full
втручань,
spectrum of surgical
як на передньому,
interventions,
так і на задньому
both
сегменті
in
ока,
anterior and
в
posterior
тому
segments
числі
of the eye,
найскладніші комбіновані
including the
втручання,
most
так
difficult
звана
combined
point-to-point surgery,
interventions,
хірургія від
pole-to-pole
полюсу до
surgery.
полюсу. І не можу не сказати, що таким певним знаковим моментом для нашого відділу було широке впровадження і використання
Marker
техніки
stone was the
трансилярної вітректомії.
implementation of
І з
transciliary
вдячністю і гордістю
vitrectomy.
можу сказати, що цей
We are
внесок
thankful that
внесли
this
Оксана
input
Степанівна, Сідак
has been
Петрецька,
made by
Дмитрій
Sidak
Сергій
Petretska,
Костянтинович, які
Dmitriev,
зробили
who were the
такі
first to
втручання
perform
на базі
such an
нашого відділу.
intervention in
Ну,
our
і, звісно,
department.
наша сьогоденна практика
The
це
2 days practice
здебільшого травми
includes
бойові.
mostly combat
За
trauma.
останні 3 роки ми
During the
виконали
last
майже
3 years, we have
1000
conducted
хірургічних
almost
втручань.
1.5
Ви
thousand
бачите,
of
що
surgical
відсоток,
interventions,
вітректомії
and the
становить
percentage
майже
of vitrectomies
половину від,
is almost
виконаних
one
втручань.
half of those
Різні
interventions.
частки – це і проведення
Other
факоемульсифікації,
interventions are
це проведення
phacoemulsifications,
ендопластики,
iridoplastics,
кератопластики.
keratoplastics,
І зараз, оскільки ми
And
маємо справу з такими
now we are
складними випадками,
dealing
про
with
які
such
сьогодні
complex
казали
cases that were
попередні
reported
спікери, і на чому
previously,
наголошувала Наталія Іванівна в своїй
as
доповіді,
Natalia
присвяченій
Ivanovna mentioned in
бінокулярній
her
травмі
report.
ока. Можу сказати, що
Most-
більшими такими проблемами, які
The most significant
значно
problems, the most
ускладнюють нашу
significant
роботу, це
issues
є погана
are
візуалізація
poor
нашого дня,
visualization of the eye fundus,
необхідність виконання
the
вітрокулярного
need for
втручання при
vitreoretinal
майже
intervention
відсутній, візуалізації
in
через
absence
розвідку.
through
Ну, і,
the
звісно, для цього
through the
ми
good
мусимо,
visualization through the
володіти
cornea.
технікою
Therefore, we
виконання
need
вітректомії з
technique for
використанням
vitrectomy
тимчасового операційного
using
кератопротезу. І,
temporary
така хірургія на сьогодні
prosthesis.
є,
Such
найбільш,
surgical operations now
затребуваною
is the
нашому
most
відділі,
needed
і
in our department,
значно збільшується кількість
and the
таких виконаних
number
втручань.
of such
Зараз хочу
innovations is
продемонструвати
increasing.
кілька клінічних
Here
прикладів,
are
з чим
several clinical
приходиться нам
cases
мати справу.
of the things we have to do
Сьогодні
with.
майстер-клас
Got a
був
master class
присвячений
today
внутрішньоочним
about
стороннім
the
тілам,
intraocular
але
foreign
не
bodies.
є виключенням
However,
і дуже важливими для...
other issues are also very serious.
Добре, дякую.
For example,
Наприклад, ось цей клінічний
this
випадок, ви бачите,
clinical
не
case,
внутрішньоочне
you
стороннє
see
тіло,
it's
але
the
це
foreign
стороннє
body,
тіло,
but it's a
яке
foreign
ми
body
видаляємо
with
через
removing
нижнє кон'юнктивальне
through the
склепіння,
lower
воно розташоване
conjunctival body.
було в парабульбарній
It was located in the
півковині. Одним
parabulbar
кінцем воно дійсно виглядало через нижнє
parabulbar
кон'юнктивальне
adipose.
склепіння, спричиняло у пацієнта постійне подразнення,
It was
постійні виділення.
causing
На жаль, це
continuous
стороннє тіло не
irritation.
було
This foreign
рентген-позитивним,
body
то
was
тому воно не
X-ray
було
negative,
помічено на попередніх
therefore it
етапах
has been not
евакуації,
noticed at the
але
previous stages of
при таких
evacuation.
потрапленнях таких уламків
However,
графіту ми
such
маємо справу
shards
з порушеннями заднього
result
сегменту ока або
and
як
distortions of the
артеріальної
posterior
ділянки,
segment,
так званими
the
посттравматичними
equatorial area,
хоріоретинопатіями.
with
На
post-traumatic
даному
chorea
слайді хочу показати, що
retinopathy.
величезні сторонні
This
тіла
video
ми маємо
demonstrates
справу
huge
зараз
foreign
дійсно
bodies,
так як і екстраокулярні,
both
так і
extraocular
інтраокулярні.
and
Наприклад, це
intraocular.
фрагмент
For
хірургії
example, it's an
полюсу до
element
полюсу.
of pole-to-pole
Тобто, що ми
surgery.
знали, що у цього
We
пацієнта
knew that this patient
інтраокулярно
has got
знаходиться великий
intraocular
уламок
huge
скла.
shard of
Отримав
glass.
він травму,
He
коли
was
перебував
traumatized while he
в
was
автівці,
in a
і
car,
на них впав дрон.
and a
І
drone has
такі
attacked them.
скляні уламки
Such
були
glass
повсюди,
shards were
а
all
цьому
everywhere.
повезло уламок розміром 5
This eye was unlucky. This was a shard 5 to 6 millimeters. It penetrated the cornea. During vitrectomy with keratoprosthesis, we removed this shard of glass, then replaced the temporary keratoprosthesis and continued with surgery. We were lucky the retina was smooth. The foreign bodies we are dealing with, metal shards, the metal shards are somewhat easier. They can be held while they are in safe position. They can be held with a magnet. Glass foreign bodies are more dangerous, they're slippery, and they should be held tightly with a forceps or with specialized devices.
Ось, наприклад, також стороннє тіло – це
Here's the foreign body.
таке тверда якась
It's
порода,
some hard element, probably shrapnel, piece of shrapnel.
Знову ж таки, як сьогодні вже казали в нашій секції,
As we've discussed it today,
задній капсулорексис,
the access is through posterior capsular axis, and the element is removed through the corneal tunnel. Back to the name of our report, we've been talking about traditions and innovations. One of the innovations of recent years is the improvement of intraocular foreign bodies using the combined computer tomography and X-ray localizer of Comberg. The benefits are: the patient occupies horizontal positioning during CT, the X-ray localizer can be controlled easily during the conduction of the assay, and the coordinates of the foreign body will be most close to its natural location, exact natural location. Speaking about traditions of the traumatology school, there is a large number of scientific research associated with iris plastics. Special attention has been paid to iris prosthesing. There are certain limitations regarding the iris prosthesing at the early post-traumatic period. Now we are successfully using all innovations and implementations of closed iris plastics and the reconstruction of the interior segments when there are no changes of retina
анатомічного і функціонального результату.
enables quick anatomical and
Хірургія
functional
інфузу
results.
полюсу
A
це
pole-to-pole
складна
surgery is
хірургія,
a
це
complex
важка
surgery. It's a
хірургія.
difficult
Якщо
surgical
я інколи дивлюсь
operation.
конгреси, офтальмохірурги демонструють відео
Sometimes
і
I see the
ставлять
videos
таймінг,
of
скільки
ophthalmic
часу пішло на
surgeons
виконання, наприклад,
demonstrating the
якоїсь
time
там
required for
факоемульсифікації і
particular
змагаються, у
operations
кого
like
менше часу зайняло
phacoemulsifications,
проведення філігранної
checking who
хірургії.
was the
То в даному
fastest.
випадку ми
In
програли
this
всі
case, we
таймінги.
would lose
Наші
all
деякі
timings.
операції
Some of
тривають
our
понад
operations
5 годин.
last over
І
5
це
hours.
величезний труд.
And that's a
Чому?
great
Бо,
labor
по-перше,
because
складно
it is difficult to
візуалізувати
visualize the
Ви бачите,
intraocular
на цьому відео ми
structures.
пішли
In this
спочатку на
video,
перший етап. Ця рогівка,
it's
яка
the first part.
виглядала майже
Initially, the
безнадійною, все ж
cornea
таки
was
дала
looking
можливість нам
almost
виконати
hopeless,
перший етап,
but
провести
we managed the
вітrectomію.
first
Розправили
stage
сітківку
doing the
перфорографічною
vitrectomy,
сполукою, важкою,
smoothening
про неї
the
вже говорили.
perfluor
Вона буде
organic
виправдувати
liquid
сітківку,
to smoothen the retina.
донизу.
It is pressing the
Наступний
retina
етап ми розуміємо,
downwards.
що ми вже
At the
з
next
такою
stage,
рогівкою не проведемо, то замовлений був
we
трансплантат.
ordered for a
Пацієнт
transplant,
вже йде на хірургію з
so the
тимчасовим
patient goes
кератопротезом, трепанація
with
рогівки,
the temporary
фіксація
keratoprosthesis.
інтраопераційного
Here
тимчасового
goes the
кератопротезу.
fixation of
Він дає
temporary
wide field
temporary
visualization.
keratoprosthesis,
Можна
resulting in a
виконувати
wide
будь-які
field
такі
visualization,
маніпуляції, як тут, наприклад, ви
enabling
бачите,
any
тут
precise
тонічною
manipulations.
сполукою виконується пілінг
Here you
внутрішньої
see the
межової
peeling
мембрани, що
of
є дуже
internal
важливим
membrane,
етапом для
which
попередження
is important
проліферативної
stage
вітреоретинопатії в таких
for prevention of
травмованих очах.
vitreoretinopathy in damaged
Цей
eyes.
пацієнт насправді
This patient
постраждалий. Ви
is a
бачите, він
civilian.
поступив до нас на
He
праву
arrived
нозу, і, на жаль,
with a
по
zero
неурологічному
vision
нашому
acuity on
явленню
right
воно не
eye.
допомагало.
The eyeball was completely destroyed.
Етапі
At the previous stage,
про це він був повідомлений,
he was
але
informed about
ліве
this,
око з
but
першої
his left
зеркальне
eye,
з циліохоридальним
with
відшаруванням
ciliachoroidal
сітківки,
displacement and
він
retinal
поступив в
displacement,
інститут, був прооперований, і
he
ось
was
станом на
operated,
зараз
and
цей
as of
пацієнт
now, this
максимально
patient
контрольовану гостроту зору
has got
має
vision
6
acuity
сотих. Він має прозорий трансплантат.
0.6.
Ось це картиння, яке тут зверху, це залишок
He's got a
капсули,
transplant.
ми з вами залишили,
These are the
коли
remains of
знаходиться
capsule
на перманентній
because
силіконовій
he's
тампонаді,
receiving
для того, щоб
permanent silicone
цей залишок
tamponade,
тримав, міграцію
and
силіконової
that
частки
remains of the
силікони
capsule
до передньої
prevents the
камери.
migration of silicone into
При
anterior
відсутності
chamber.
єлектроштоликової
In
діафрагми,
absence of
при
iris
триманні
diaphragm
силіконової
and
тампонаді
during
рогівка
long-term
страждає
silicone
всередині.
tamponade,
Але
the cornea is being
щільно
damaged from
наших
inside,
військових страждає
and
внаслідок
also the cornea is
значних
damaged due
порушень,
to significant
анатомічних
anatomical damage of
придатку
conjunctiva and eyelids. Therefore, in order to conduct post-operative management in patients with such serious wounds, especially with eyelid colobomas and post-traumatic lag of ophthalms, it is not recommended to perform blepharophy in such patients in absence of sufficient tissue of eyelids. So we recommended to use a perforated conformer made of polymethyl methacrylate. That's rather rigid substance. It enables the access of eye drops to transplant. There are several modifications with several perforations. This patient has got a xerotic dry cornea. This is the condition after keratoplastics. You see that without a conformer, this transplant is damaged because the eye slit is inadequate. Under certain conditions, only conformers can be used, but we recommended using it in combination with amniotic membrane. As a result, this transplant can be grafted in a transparent way. providing transplant conditions. We are the only ones using the vitreoretinal endoscopic technique to perform vitrectomy. Here I'm demonstrating an element of the video with a patient with a severe trauma, with a retinal detachment and multiple ruptures, who has got his cornea not transplant. We were not planning conducting an autokeratoplastics or donors grafting, but still we managed in a very short term conducting vitrectomy. Here you see the removal of epiretinal membrane. The macula is denudated. By the way, the macula's condition is good. The whole manipulation is performed using the perfluoroorganic substance, enabling buying us time for keratoplastics. On one hand, the displacement of retina requires surgical interventions as early as possible. On the other hand, early keratoplastics at the post-trauma period is associated with the loss of the graft transparency. We are widely participating in all congresses and participating in all possible events. We are well known and performing not only as reporters, we're also publishing the results of our studies. Less than within a month we published an article associated with a significant number of data in patients with chorioretinitis. Therefore, I hope we will hold the tempo. We're thankful to everybody who visited our section today. I believe we had enough time, so after several minutes of break, we'll go for the video contest.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини, не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом, професор Скрипниченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуально в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників, і ми займаємося такою складною патологією, як овоїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити